Hello, and welcome to the Lifestyle Management Center's virtual Integrative Health Symposium. Now, my name is Marti R, and I, along with Dr. Daniel Ganu, will be co-hosting this two-day event. Now, Dr. Ganu is the founder of the nonprofit Lifestyle Management Center in Ghana, Africa. So on day two, stick around if you can, because Dr. Ganu is scheduled to speak about his miraculous health recovery, which led him to launch the Lifestyle Management Center in Ghana, Africa. Now, he'll also share his vision for the center and his plans to turn his vision into reality. Now, Africa is home to 54 countries and about 1.2 billion people. So over the next decade, Africa is poised to experience the world's largest increase in deaths due to non-infectious diseases. Now, this symposium will feature 4 speakers over the next 2 days who will cover topics of lifestyle, nutritional, and integrative approaches to preventing and treating chronic diseases. So immediately following each speaker, we will begin a question and answer session to address any questions you may have. Tamika Robertson is our technical admin and will be assisting us in the Q&A session. Now, you can chat with each other by making the drop-down option in the chat and make sure it's switched to everyone. But if you can, use the Q&A tab to submit your questions, if you can. Now, also, don't worry about taking notes during the session, because we'll send each registrant a link to the recording of each day's sessions, and because we really want you to have the opportunity to stay focused on each speaker's life-changing message. So now I would like to introduce our first speaker. In 1997, Dr. Baxter Montgomery opened Montgomery Heart and Wellness in Houston, Texas, USA, right in the shadows of the powerful and world-renowned buildings of the Texas Medical Center. He's a board-certified cardiologist and cardiac electrophysiologist. So throughout the years, Dr. Montgomery has treated thousands of patients with severe cardiovascular diseases. Now, here's a very interesting note. I've heard Dr. Montgomery speak of his experience in treating patients by employing state-of-the-art procedures, interventions, electrical ablations, and medications. And yet, still many patients continue to grow weaker and sicker. So he began researching the role of nutrition in disease reversal and found that plants were a common denominator in determining wellness. So today at Montgomery Heart and Wellness, Dr. Montgomery focuses more on nutrition and wellness and tries to prevent the need for the other medical services as he helps patients achieve optimal health and wellness. He also has a docuseries that will be coming out in a few weeks that will follow the health journey of patients on their journey to optimal health. And that's going to be at heartandsoulofchampion.com. And it should be a link in the chat for you to go and check it out and be ready to see it when it live streams starting in a couple of weeks. Now, we're very fortunate to have Dr. Montgomery join us today to share a novel integrative health approach to reversing chronic illness. So please welcome the founder and chairman of the Montgomery Wellness Center, Dr. Baxter Montgomery.
Well, thank you very much for having me. and of course, good morning from where I am, and perhaps good afternoon in other parts of the world. It's a pleasure to be in your conference, and it's always a pleasure to share knowledge with anyone who's willing to seek it regarding natural health. You know, I made a quick note here in your intro. Africa, the continent of Africa is about to receive its largest increase in non-communicable deaths this year. So that was an eye-opener for me because, of course, you know, we are used to dying from non-communicable causes here in the United States. And I'll share a lot of that data with you in my conversation. I'm going to get right to my presentation. I'm going to share my screen and just let me, someone just give me a thumbs up or something, let me know that you can see my screen pretty well. I've done some of these talks before and I've gotten a third of the way through them and said, we can't see your screen. But anyway, the topic today is going to be that on integrative health. And I think it's the future of medicine here in the West and perhaps worldwide. And integrative health is an approach that we have been using in Montgomery Heart and Wellness probably for the last better than decade or two, largely because we've been in a health crisis for a long time. And I think it's been amplified in the last 2 years. This graph here shows you life expectancy in the US, and we've reached an all-time low in the 21st century. And if you notice, from 1995, there's been pretty much a steady increase, maybe a few plateaus here and there. In 2014, for the first time, there was a significant dip in lifetime expectancy from 2014 to 2015. There was a bit of a plateau after that, maybe another dip. So there was a slight decline from 2014 to around 2016 in life expectancy. There was then an increase after a while here, maybe back to where we were in 2014 and 2019. However, then there was a steep drop from 2019 to 2020. Now, of course, the COVID pandemic did not hit in 2019, so we certainly cannot blame it on that. Then there was another steep drop from 2019 to 2021. I'm sorry, 2020 to 2021. And we don't have the data in from 2021 to 22. Excuse me, 22 to 20. 21 to 22 data is not in. I've looked it up recently. However, some people speculate that it's still maybe going down. So this is a very steep drop in life expectancy here in the United States. And the vast majority of it is due to cardiovascular disease, which I'll go through in a minute. But the big problem we suffer from here is that sickness has become the norm. And so starting with cardiovascular disease, in 2019, we had about 874,000 deaths, almost 875,000 deaths just from cardiovascular disease alone. To put that in some level of perspective, in 2020, globally, there were probably 19 million people who died from cardiovascular disease compared to only about 6.73 million people who died globally from COVID. That's about 35% of the cardiovascular disease deaths. So despite how horrific COVID was, it paled in condition to the annual pandemic we have with cardiovascular disease. From 2015 to 2018 in the United States, Black men and women are about 60% prevalent from cardiovascular disease. It's the highest race prevalence that we have here in the United States. There's some biological reasons for that. And the top causes under cardiovascular disease, as we know, are coronary heart disease, which is very prevalent here. Other forms of cardiovascular disease, there's stroke, there's high blood pressure, heart failure, and other diseases of the arteries. This slide I use to give some perspective. So this slide gives the number of people who died in all the different wars, all the American soldiers who've died in the different wars over the years. So you start with the American Civil War, roughly 620,000 people. Some people may dispute this number, it may be 700,000, but roughly 620,000 men, U.S. soldiers died in the Civil War. The greatest loss we've had. World War II is second to that. But every year, as you can tell, we have more deaths from cardiovascular disease than we had deaths in the Civil War. So it's almost like just with cardiovascular disease alone, we're fighting and losing men to this war every year. But then if you add cancer to it, so cancer in the US causes roughly 600,000 deaths. So cancer and cardiovascular disease combined, you see somewhere around 1.4 million deaths. And this is roughly every year. And you compare that to all the deaths of every soldier we lost in all the wars in the United States history. That's roughly about 1.3 million. So in essence, cancer and cardiovascular disease combined cause more US deaths each year than we've lost all the US soldier deaths in the history of the United States. So it's almost like we're fighting every war and losing all those deaths every year just with cardiovascular disease and cancer alone. So it's pretty costly. And the unfortunate part about it is something that it goes unnoticed. So we were having a major war here in the United States and we had 600,000 deaths. It'd probably be hard to cover that up, but it seems like the cancer deaths and heart disease deaths here in the States is something that goes unnoticed, or at least is accepted as the norm. It's amazing cost to us. It was a roughly 10% increase in costs in 2020. The public health spending more than double in 2020 for chronic illnesses. The health expenditure by our federal government is about 36%. It's the largest pusher of our debt. The government share increase, we spent about $12,500 per person here in the United States in 2019. And so it's a huge burden on us economically as a country. And of course, individuals, a huge burden, because the number one cause for bankruptcy, the last time I checked, was bankruptcy from medical bills. So it's a major problem financially as well. So needless to say, we need a paradigm shift. And so this is something that we've been promoting in our center, and of course, in the talks that I've done over the years. And lifestyle intervention really needs to be the first and foremost intervention. Lifestyle intervention should be the first line treatment of choice for prevention, control, and reversal of all chronic illnesses. Now, we say in the West, the Western medicine is great for acute illness. Certainly if you break your leg in a motor vehicle accident and some trauma event, we have excellent care for that, and it's probably second to none. Maybe even acute exacerbations of chronic illnesses, acute heart attacks, or acute exacerbation of lung diseases, we do extremely well. However, even in many of those conditions, lifestyle intervention plays a critical role. I've personally taken care of patients in the throes of a heart attack, acute decompensated heart failure, and we've had to treat them with a lifestyle intervention because they were too sick for the surgeries or interventions or the like, and they actually turned around and did well. So I'll share some of those examples with you in my presentation. So lifestyle intervention isn't something only for prevention. It is a very, very powerful intervention, even in the acute setting. And at the very least, it should be an adjunct to anything else that's done for a patient who's acutely ill. So what I want to do, the next series of slides, is talk about our nutritional medical integration. I want to share with you some of the nuts and bolts of what we do when we evaluate patients in our clinic. So as an overview, I want to talk about our clinical assessment of the patients, how we deal with that, nutritional wellness assessment. We're going to talk about some of the integrative therapeutic interventions. We've added some interventions since I've made some of these slides. We'll talk about our clinical follow-up, which is very important. And then we'll share some of our data. We've scientifically validated a lot of what we've done. And then we'll deal with some clinical cases as well. So when a patient comes to see us, typically, they'll come in with, a complaint of one or more chronic illnesses. We typically follow the standard medical approach. We take a history and physical exam. And this is really important, especially the history part, because this gives me a chance to visit with the patient, get to know the patient as a human being. We have a team approach to this. We have a medical assistant that'll come in and do the vitals and do that assessment. I have two mid-level practitioners, one a nurse practitioner, one a PA, who will then see them either along with me or before I see them. And then I will see them and we'll discuss a care plan. But the history and physical is important because it gives us insight in terms of what the patient's concerns are, what the illness is. It gives us about 85–95% chance of making a diagnosis. And so this is important. If we do well here, then the rest of this becomes pretty straightforward. We do extensive biomarker testing. We may draw as many as 15 tubes of blood. We get inflammatory markers. Sometimes we even do extra tests that are send out labs to give us insight, biochemical analyses, and the like. There's non-invasive testing we do right in our office, echocardiograms, vascular studies. And if need be, we'll send them to the hospital and do invasive testing. I used to do coronary angiograms, electrophysiological testing, and the like. And so we cover the spectrum, and if a patient needs to be admitted, they're under our care. We don't transfer their care to anyone else. So the integrative therapeutic intervention in concept It's a comprehensive medical intervention, and it's initiated along with a nutritional detox or other nutritional plan. So when someone comes in and say, I have high blood pressure and say diabetes, I have arthritis, we'll review all their medications, and we'll have patients with maybe 26 medications or 10 medications, whatever the case may be. And we'll look at that, and we may make changes in the medications. Sometimes on day one, we can see medications that are unnecessary. So we may consider making changes. If they take a lot of over-the-counter supplements we're not certain about, we'll make those changes. And medication changes and medication weaning is a very, very important point, part of our intervention, because we often see adverse effects of medications being a contributing factor to the person's ailment. So, for example, I recall a patient coming in and they were on a statin drug, and they had musculoskeletal problems and muscle aches and pains, and they were taking 2 other medications for that. And so we started them on a nutritional detox. They were doing well. I stopped the statin drug, and those symptoms went away. We were able to not only stop the statin drug, but also the medications used to treat the side effects of the statin drugs. And so, that's one example in terms of how medication weaning can actually help the patient. In the United States, we have categorized heart disease, #1 cause of sickness and death. That's #1. #2 is cancer, but #3 is medical treatment. And so that's something that, we have to be on top of and be mindful of here in the United States, because it's very, very common for people to come in on multiple medications, and that's contributing greatly to their ailments. So then we start off with an initial food prescription. Typically, they'll meet with our nutritionists, or either sometimes I'll outline some things for them. And it depends on how detailed we need to get. Sometimes patients are so busy with their diagnostic tests on day one, we'll give them a brief overview and schedule them to come back in like our integrated care clinic, where we can focus more on nutrition. But either way, we go over the details of a nutritional plan. We review that in the context of the foods they already eat, and we try to evaluate the goals they have and the like, so we can put together something that works very well for them. And then if needed, there's minimally non-invasive medical treatments. Some patients we've had patients come in with severe congestive heart failure, arrhythmias or the like. We may give intravenous furosemide or other fluids. Some patients are volume depleted when we give intravenous saline. So we can do a moderate number of minimally invasive things to prevent them from going to the emergency room. If they are sick enough, we may have to admit them to the emergency room. We've had patients come in. One patient came in, and actually he wasn't a patient that day. He was visiting our restaurant, which is open to the public. And I was just passing through it because it's within our facility. And he said hello to me and said, "Hey, I intend to be a patient of yours one day." And I said, "Oh, great. We look forward to seeing you." And I went back to the clinic side, and it wasn't long after that someone was banging on the clinic door saying the patient passed out. And it was this gentleman. We ended up having to admit him to the hospital. So sometimes we get patients that's come in, in all sorts of conditions. We've had people come in with acute cardiac arrest. We've had to resuscitate. So I say all that to say this: we cover the full spectrum of what the patient's needs are. And we try to, treat them in the acute setting to the extent we need to, but work and transition away to where they're not requiring these medications and acute treatments. Now, excuse the busyness of the slide. A large part I have it here so you can go back and reference it. But what I want to show or demonstrate with this slide is that we have a medication assessment and optimization and weaning protocol. So we don't wean medications on a random approach. There's a standard baseline medication changes. There's an approach to week 1, week 2, week 3. Now, this is generally a guide. Obviously, we have to modify that with time, depending on what we do. But this just gives you an idea of the approach we take and the order in which we may wean medications. Now, the food prescription overview. First of all, I like to use phrases like food prescription. It's not a diet. It's really a lifestyle change. But even in the context of what we use, how we use nutrition, we use nutrition in a prescriptive approach. And what do I mean by that? There's a certain level of precision that one has to have. So oftentimes you can say, well, you need to cut back on sweets or cut back on animal protein, just follow a vegan diet or do this. And really, that's not enough. Patients really need to have very precise direction in terms of what to do and how to do it. Not from the standpoint of them understanding it, but if someone is critically ill, let's say they have a congestive heart failure, and maybe they're on an infusion of milrinone, or they have an LVAD. So this person is in very, very unstable territory. So we have to put them on a very defined and precise nutritional detox regimen. They need to know to stay on that for a certain period of time while we're making adjustments in their medications and the like. And so it's very critical for us to be very precise in what the patient eats. A deviation of a meal, one bite, drop a crumb, can send the patient to the emergency room in the ICU. And I say that not just to be cute, but really this is just based on experience. When patients deviate just a very small amount, especially if they're very critically ill, then many of them don't have the reserve to recover. Now, that doesn't necessarily apply to a large number of people who, don't have these issues, large because maybe they have hypertension, high cholesterol, and they have a lot of reserves. So they may deviate a little bit, not that we encourage it, but they're not as critical as some other people with systemic inflammatory conditions or a systemic heart failure, in which case they have very, very minimal reserve. So anyway, the general concepts that are of the food prescription is to define manipulation of nutrition. I think that's important. If I have someone on a raw detox, a cold pressed juice feast, time restricted eating, that's not meant for life, but we're manipulating what they remove from the diet to bring about certain biochemical changes. And again, there are basic objectives that we're looking for. Typically, we're trying to reduce inflammation and oxidative stress very quickly. Oftentimes, there may be other objectives. And the general experience is that basically the efficacy of this has been scientifically validated in peer-reviewed journals. And we are constantly optimizing our approach. Here's another busy slide. I'm not going to go through the details of this, but I like to show this slide, and you can reference it later, because we do have a food prescription nomenclature that we frequently use. So position 1 denotes the duration of feasting hours. Position 2 denotes the duration of fasting hours. Position 3 denotes days of intermittent fasting if they have it. Position 4 denotes days of complete fasting. Position 5 denotes food level consumed during the feasting period. So if somebody's on a 4-20, 5-2, parentheses 0 to 4b, they are feasting for 4 hours a day. They're fasting for 20 hours a day, and they have an intermittent fasting, like a 24-hour fasting days, 2 days in a week, okay? And then the foods they consume are food levels 0 to 4b, which I'll mention briefly with the food classification system is. So this person is feasting or eating for 4 hours. 20 hours during the day, they're drinking water. They're doing that for 5 days. So 5 days, they're feasting for 4 hours, fasting for 20 hours, and they do it. But 2 days, they're fasting for 2 days straight, 24 hours. So these 2 days is nothing but water. So this is a 2-day water fast with a 420 time restricted eating period for 5 days. And when they are eating, they're consuming foods from 0 to 4b. 4b foods are dehydrated raw foods. 0 is like liquidated raw juices, cold pressed juices, smoothies. 1 through 3 are solid raw foods that are not dehydrated. 4a are high fat raw foods, and I'll go through a little bit of that later. This person, they're on a 4-27-0, so they're feasting for 4 hours, fasting for 20 hours. That's water only, water and sleep, and they're doing that for 7 days a week. And there are no days of 100% water fasting, and they're doing level 0, so they're just doing smoothies and cold pressed juices. So there's some nomenclature that we use in our prescription approach. Minimally invasive treatments, vein ablation therapies, we've done lymphedema therapy, we've accommodate implantable cardiac monitors we've done over the years, intravenous infusions, vitamin infusions. We now do ozone infusions, medication injections, intramuscular supplement injections. So we do these things in our facility. We're 4 miles south of the Texas Medical Center. I practice at one of the large hospitals there. So if our patients need to be admitted, they'll be admitted under my service, and I manage them in the hospital. We do general hospital admissions. Now, I stopped doing procedures. There's some images of me doing procedures in the cath lab. I was very busy early in my career for about more than 2 decades, 23 years, doing invasive procedures, device implants, cornea angiograms, and the like. But when I decided to focus a majority of my time on our center, I now have colleagues do these procedures for me. But either way, we'll admit patients, and I'll have colleagues perform these procedures. We have very capable colleagues who do a very good job of these procedures. So clinical follow-up is very important. The frequency of office visits is extremely important. It's typical, well, in the United States, it's typical for cardiologists to see patients maybe once a year, maybe every 6 months, or not sooner than 3 months. If you don't need a stent, they may not see you very often. We're different. Obviously, we're treating more than just a cardiovascular disease, but we may have weekly visits. If someone's on a nutritional detox, they may need to see us at least 1 week within the start of the detox, sometimes twice within the week, depending on their condition. The duration may be 4 weeks in the minimum. In a 4-week period of time, we may see someone 3 times or 2 times or whatever the case is. We've had patients come in daily, depending on what kind of treatments they're getting. If they're getting sauna therapy, if they're getting ECB therapy, they're coming in being evaluated by our team with daily and getting these therapies. Food prescriptions and modifications, we're reviewing that with the patients. So we're getting them on the nutritional detoxes. Sometimes they'll do smoothie feasts, and then we'll transition them to solid foods. And then further medication optimization. This is one thing that I'm very, very keen on, is that we wean medication as quickly and as efficiently, and of course safely as we can. And so that's really important, an important part of the health. So here's some of our data. We've published our work in medical journals. Here's a defined plant-based diet utilized in an outpatient cardiovascular clinic, and it effectively treats hypercholesterolemia, hypertension, and it reduces medication. So that's an important part. Not all of these conditions are getting better, but the medication requirements lower. So we had a population of roughly 31 people. You see the demographics here. And 80% were Black Americans, 10% were Hispanics, and 10% white. Most had an average mean BMI was 37.5. And a pretty good spread across the chronic illness types. Our recruiting criteria, entry criteria, was hypertension, hypercholesterolemia, and increased BMI was a criteria for them coming in. And so here's the food classification system. This is a busy slide, but in essence, in summary, 0 is raw liquid food. So if you take some, make a smoothie, a cold pressed juice out of it, it's something that you'll have there. And I'll kind of go through some of the explanation of why I gave you the classification the way I did it. The lower numbers are healthier, the higher numbers are least healthy. We don't recommend going past 6. This is plant-based 6. Once you get past 6, you have the animal protein and excessively processed plant protein foods and carbohydrates all up here. So we detox usually from around 0 to 4B, sometimes just 0, sometimes 0 to 3, and it just depends on the condition. But as you can see here, the numbering system simplifies it, plus it tells you exactly not only what you're eating, but how it's prepared and where it comes from. So if we look at much of what the patients in this study consume, they had about over an 800% increase, anywhere from 300 to 800% increase in plant foods. And so that was a huge change there. We did not use white potatoes large because it was a raw diet. So that's why this part decreased. Also fried potatoes went down, and all of these processed grains. So if you were imagining putting somebody just on a vegan diet, these numbers would go up a certain amount, but these numbers would also go up, fried potatoes or whatever, if you just say eat vegan. So that's why you have to be precise in terms of what you're recommending. Nuts and seeds, of course, went up. Notice, let's see here. I don't see my, here's my avocado data. So avocado data, they went from baseline 0.1, says an 800% increase in avocado consumption. So keep note of that because the thing is that oftentimes people say, well, avocado's too high in fat, but it's a healthy fat, and we got benefit when people increase the avocado consumption. So what were some of our findings? Hemoglobin A1C and HSCRP. Hemoglobin A1C decreased significantly, and this was a statistically significant change. So we had about a 3.4% reduction in hemoglobin A1C in just 4 weeks. Now, let me pause and kind of, dig into that for a minute, because a 3.4% reduction in hemoglobin A1C in just 4 weeks, that is about 2 to 3 times the reduction in hemoglobin A1C that you get in prescription, some of the brand prescription pharmaceutical drugs for diabetes, typically. And it takes about maybe 6 weeks, 3 months, no, 6 months. That's the data they typically have when they get, say, about a 1.2 to maybe 1.6% reduction. We had that in just 4 weeks. Now, you'll say, well, wait a minute, hemoglobin A1C is the average blood sugar for 3 months. So how are you seeing a change in that parameter in 1 month when it's a 3-month measure? Well, the other factor that contributes to hemoglobin A1C is blood sugar fluctuations. So if someone's having a lot of wide blood sugar swings, then the hemoglobin A1C will be increased or influenced by just the fluctuation of blood sugar, not just the average blood sugar, the average fasting blood sugar. So oftentimes, my theory is that it's the postprandial blood sugar. So if you're consuming foods, especially animal proteins that are mixed with carbohydrates, you're going to have a high postprandial blood sugar. And it'll come down over time, but after every meal, you're gonna have an increased blood sugar, then it comes down, increased blood sugar, then it comes down. So then your actual meals, even if they're on a so-called diabetic diet, may be triggering these high fluctuations. Now, I'll have to, prove that in another study, but that's a very, strong consideration I have, in that the postprandial blood sugars are contributing to a lot of these swings. HSCRP, we saw a 30% reduction in C-reactive protein. Now we've had data for almost 1.5 decades or more of reduction in C-reactive protein. We just published it in this study, but we've been seeing this over the years. So inflammation goes down pretty rapidly. Here are changes in blood pressure. We saw from baseline to the first week, there was a very significant drop in blood pressure, then another drop from week 1 to week 2. But notice from week 2 to week 3, there was kind of a bounce up in blood pressure, and it sort of came down and plateaued, systolic. You see it also with the diastolic, down, down, then up, then kind of back down. And we've seen this also in many patients. We put together data for 200 patients. I analyzed it. We saw the same, down, down, up, and then down. And so something happens around week 3. I don't think patients are calling each other and conspiring to not comply with the diet. I think what's happening is that there's probably some physiological process, a biological process. I think it's a detox process that happens universally around this time, to where maybe toxins are being moved out or the like. And so you may get a transient bump in the blood pressure and it comes down. One could argue that with weaning medications, and maybe medication weaning can contribute to this. And I agree with that being a possibility, but I think there's some biological process that's undergirding this as well. And of course, total cholesterol went down, LDL cholesterol went down. Now, effects on medications. Now, these are total medications from baseline. They were on 2.6 medications on average. Week 1, it went up to 2.7, but overall it came down to 1.6. And that's those are the blood pressure medications, by the way, not the total medications. So we also looked at inflammatory markers like lipoprotein(a) in this 4-week period of time. And we were the first to show in the medical literature a 16% reduction in lipoprotein(a). Total cholesterol down, LDL cholesterol went down. And these changed all in just 4 weeks. And this is nothing that is, you're not months and what have you, 10 years waiting for something good to happen. This is in 4 weeks. And I would surmise one day we may do a study where we do week-to-week measure of these, but I think a lot of these changes are happening within the first week or two. So we see those changes that are happening significantly. Here's some other biomarkers. I want to point out that LDL cholesterol and LP(a), these are percentage changes that they're getting. Notice how we get a roughly 6% drop in weight. And then the biological parameters have about a 2 to 3-fold reduction compared to the anthropometric changes. And then when you look at C-reactive protein, it's not on here, but as I said before, that was a 30% drop. So if you look at the biological changes, the changes that are happening at the cellular level, at the tissue level, you see anywhere from a 3 to 6-fold improvement compared to just weight. So, and we've seen consistency among that. Here's the C-reactive protein, 30% reduction. IL-6, inflammatory marker, 23% reduction. Plaque-2, a vascular inflammatory marker. This measure of stability of plaque, the increased risk of heart attack, 16% reduction. So anywhere from about a almost 3 to 6-fold reduction in the biological, about at the cellular level, the change we're seeing at the cellular level compared to weight. So when you see someone on this plant-based diet, they may lose a certain amount of weight, you can almost say, well, you're having a 3 to 6 time improvement inside your body biochemically and biologically, which is even greater. So it's really a fantastic thing to know that the body's healing, first and foremost on the inside, before you can really see much of the healing on the outside from the standpoint of at least weight reduction. And of course, white blood cell went down. Now notice we saw again, C-reactive protein is pretty high. Hemoglobin A1C was only 5.9, barely in the pre-diabetes state. And that's one thing I did not point out earlier, is that it was not very high. We did not recruit diabetics. So to see a large C-reactive protein reduction in a very short period of time with this powerful, it shows that the intervention is extremely powerful. And in white blood count, which was 6.3, went to 4.8. Now this, again, was within normal range, but it had a very significant reduction, which means that a lot of people had white blood counts that were normal, but they were not really normal. They were statistically normal, but not biologically normal. And so that's an important difference there. So we did a program for patients with coronavirus, and we talked about the immune system. This is something that really plagued our community. And one thing we really wanted our listeners to do is to really boost their innate immune system. Really, people talk about immunity, and certainly vaccines give you exposure to the antigen and theoretically make antibodies. But even before you get to that point, you have an innate immune system. And if this innate immune system is in tip-top shape, you really don't need exposure. It just knows what's foreign. And if your body's optimally nourished and in biochemical balance, your innate immune system gives you immunity even before you've been exposed to a pathogen. And it takes care of the pathogen. Then the adaptive immune system, after 2 weeks, would then create antibodies and T-cell, B-cell memories for the next time. But the first time you see something that's foreign, you should be able to take care of it. And what we did in this context is that we recommend that people create biochemical balance. And to look at this, you have what's called reactive oxygen species, and antioxidants can help balance this out by donating electrons to these reactive oxygen species. And the antioxidants are plant-based foods. They work well to prevent to prevent destruction of chronic illnesses and destruction of your tissues. So you like to look at it as in a balance. Reactive oxygen species are necessary because our immune system uses them, but we in a Western diet has an excess number of reactive oxygen species, and that puts us out of balance. So too many reactive oxygen species in our system creates oxidative stress. So more antioxidant brings it in balance. So what's antioxidants? As I said, plant-based foods, but things like grounding, getting away from electronic, high EMF formulation. So here you see if you're consuming lots of toxic food and you get exposed to a bacterium, something like coronavirus, that increases oxidative stress. It throws you into further imbalance. And then that puts you at risk for succumbing to an infection. So there's a close relationship to what potentiates these non-communicable and non-infectious disease as what potentiates the infectious disease, because the immune system, when it's in optimal condition, then it allows you to fight infectious disease very effectively as well. So oxidative stress, the immunity, and here's some things that we recommended for our patients. But coronavirus still is a major issue on the minds of our patients, even now after the pandemic. And so this is something we've had to integrate into our practice, not only in terms of reassuring people that their immune system are effective, but also giving them lifestyle approaches to help. And so an anti-rich diet. So anyway, we wanted them to stay positive. So let me go through some patients that we had that we managed in our clinic. Here's a gentleman who came to us, and this was the first visit. He had a history of high blood pressure, diabetes. He was on a pretty hefty dose of insulin. He was on metformin. He was on furosemide. He had lots of swelling. He had chest pain, and he was on several medications for blood pressure. When he came into our office, his weight was 284.5 pounds. His BMI was 50, blood pressure 170 over 111, heart rate 122. So I did an evaluation. We felt that based on his heart condition, we should admit him that day. So even though it was our first time seeing him, we admitted him. Here's his 1280 kg. It shows a typical atrial flutter with essentially a 2-to-1 conduction. And so we felt we had to go and be cardioverted at least. Now here are his data. Now some of his data is when we admitted him, and then some goes beyond his hospital admission. I'll sort of walk you through it. But we saw that his GFR, glomerular filtration rate, which is the measure of how well the kidney is filtering. So the higher this number is, the better. The lower this number, the worse. And the creatinine, which is the molecule that we measure GFR with. Now, there's another way of measuring GFR, but creatinine is one way. The higher this number, the worse. The lower this number, the better. Because if you're filtering the kidneys very well, then it filters the creatinine out. The creatinine level goes down. If you're not filtering the kidneys very well, then the creatinine builds up, and so the creatinine level goes up. So that's a simple way of looking at this. So when he came to see us, his GFR was 20. This to give you some perspective. When the GFR goes below 15 and stays there, that's when they recommend dialysis. So he's very close to being at a point where he would have dialysis recommended. But anyway, he got on our detox regimen. We put him on a smoothie feast, even in the hospital, and his GFR improved pretty significantly, and the creatinine went down. And so we saw these changes initially. Now, people often ask about, well, what about protein? Can you get protein from plant foods? Where does the protein come from? And are you going to get protein on smoothies? Now, granted, this gentleman came to us. He was eating a standard American diet. In fact, he owned a barbecue restaurant, if I remember correctly. He was not only eating barbecue, he was eating other things too. But his protein level, the main protein, albumin, was about 1.7. And so this on day one. So we started to detox here. So the protein did not drop. Not only did not drop significantly, but on the detox, it went up. And so it went up to almost 3. And then what happened here is that he was discharged and he went home and he ate something bad. I think he had some chicken soup or oyster soup or something. And his albumin dropped significantly back down to where it was baseline. We put him back on the detox 0 to 4B, and his albumin went up. So on a raw plant-based diet, in this patient, the protein went up. Well, what was going on here? Well, what was going on here was that this gentleman had a systemic inflammatory condition. That's why his kidneys were compromised. He was swelling, and he was leaking albumin. So the albumin was low. The protein was leaking out of the bloodstream. So that was because of inflammation. Once he started to detox, as you saw from our data, detox reduces inflammation about 30% in 4 weeks. A lot of that happens within the first week or two. So when we turned off the inflammation, then he was able to maintain protein within his bloodstream, and the albumin went up. When he went back and ate the bad food, he turned the inflammation back on, and then the albumin dropped, because it's like turning on pulling the plug from the faucet, things seep out. And so it happened again, and it dropped pretty rapidly. When we went back on detox, we turned inflammation back off, and the albumin went back up. So again, this is what we see with protein. In this patient, he had a greater than 50% medication reduction. There was a correction in his heart rate and the heart rhythm. We converted him to a normal sinus rhythm. His leg swelling went down, improving his albumin level. His overall well-being was improved with this integration. So this whole concept of integrative health, I want to give you a few conceptual slides here to sort of bring it together. And we start off from the standpoint of integrative health starts with the foundation of optimal nutrition. Nutrition is our foundation because it allows for natural healing. You know, we do use target supplementations. We use other modalities, as I said, you know, ozone therapy, et cetera. We use infrared sauna. But we really like to start someone on an optimal nutritional regimen. If someone's doing like that raw detox and following it effectively, they get a great amount of clinical improvement, and it serves to be a powerful foundation to other modalities that you add to help them with healing. Other nutritional interventions are added as needed. So I have a mantra, if you will, maybe you call it the Montgomery doctrine, whatever, but it's foodaceuticals, you know, is the foundation of your health. Nutraceuticals only as needed. Pharmaceuticals as a last resort. Foodaceuticals is a foundation. Nutraceuticals, that's supplements and other things, only as needed. And pharmaceuticals as a last resort. And so I think if we take that approach, it really helps out in terms of optimizing patients' overall well-being in an efficient manner. So the nutritional intervention, again, fasting and cleansing, we use a lot of that. Whole food detox, education is really important, and also group support groups are important with that. It's important that people understand conceptually what they're doing because it helps them go through the process, et cetera. Advanced recipe designs, small group shopping and gardening tools. These are other accessories that we provide on the nutritional side. From a targeted nutrient supplementation side, we do nutrient level testing, microbiome testing. Oftentimes we'll provide intravenous infusion, of course, saline, vitamin C, Myers cocktails, intramuscular sub-Q injections from B12, for example. And then there are all supplements that we may use to assist patients as they transition. Fitness, we have exercise trainers on standby at one of our local gyms. Our patients go and work out. We have exercise prescriptions and things like that. And we try to get them to progress to advanced levels of fitness. We try to get the person who's in the wheelchair to get to walking heels and running heels, because it does not only does them good from a physical standpoint, but it does them good psychologically and mentally, and that improves their overall well-being. We also refer out for things like acupuncture and chiropractic therapy as well. So these are all part of our adjunctive approach. So we like to utilize all these modalities and integrate them, you know, under one roof, if you will. And we try to do this in a way that we can provide some synergy in their effects and synergy in their benefits. Oftentimes people know to do these things. They may be taking supplements, or they may go and see a chiropractor from time to time, but they're not putting things all together. They're still eating trash food or whatever, and they're getting some relief, but not the optimal relief that they can get. So again, thank you very much for your time and attention. And I think I've left a good amount of time for questions, which is really my favorite part of the presentation, because I really get to hear from you and address questions, because oftentimes it lets me target what people are thinking about. Thank you.
Okay, thank you. Thank you so much, Dr. Montgomery, for the wonderful and eye-opening presentation on chronic diseases. I appreciate the fact that your presentation is based on empirical research. This is not a fable or a cooked information, but evidence-based, which is very much appreciated. But one thing that struck me in your presentation is how U.S. expectancy has taken a downturn. It is interesting and amazing to see that. But I believe our audience may have questions for you. So at this very moment, I will turn over to Tamika to go ahead with the questions Q&A. Tamika, over to you.
Hello. Hi, Dr. Baxter. We had a question that was submitted prior to the symposium. And she asked, how does one eat to burn fat when on a treatment for cancer that includes hormone blockers?
So how can someone burn fat?
Yes.
And if they're on a treatment that has hormone blockers.
Yes.
Yeah, it's now it can be very tricky and not only related to hormone blocking treatment, but just any treatment for cancer, because the treatment for cancer in general, and I'll speak about treatment for cancer in general, not just specifically related to hormone blockers, because it's very tricky, and oftentimes you have to overcome the treatment as well as the disease. And we've had a number of people who have cancer who, decide to not undergo those treatments, largely because the treatments have adverse effects. So, for example, with prostate cancer, many men, if they have advanced prostate cancer, maybe they'll get surgery initially, but they'll be recommended for hormone blocker therapy if, like, they have a recurrence or increase in PSA. And in that setting, the hormone therapy gives them lots of side effects. Many of my patients are men who are in that predicament. I tend to recommend that they not undergo the hormone therapy in that situation, but undergo nutritional intervention. Now, I'm not necessarily telling them what to do. I'm just saying that they should consider it or discuss it with their urologist. But the hormone blockers are problematic. And that's why you want to start with the foundation of optimal nutrition, because with that, you'll fight the cancer. You'll allow the body to fight the cancer very effectively. And maybe you can be allowed to be weaned from or taken off the hormone blockers if your body starts to recover in a natural way. Oops, I don't hear you. You're muted.
Tamika, you are muted.
Sorry, thank you. The next question is, on the inflammatory markers, what was the comment that you made about IL-6?
Yeah, IL-6 was decreased, I think it was about 16%, if I remember correctly, from that. This is one of the cytokines that are measured. If you remember, people with acute illness, and they talked about this during the COVID pandemic, people in these cytokine storms. Cytokine storms are not unique to COVID. We see cytokine storms in other acute inflammatory conditions, whether it's infectious or triggered by some other mechanism. So and really it's just the immune system. The way to think about this is that if you have an immune system that's in disarray, then that immune system will react adversely and pathologically to a foreign invading substance. So, for example, I often use this analogy. Let's say you have guards around your house, and the guards are there to, prevent, intruders. Maybe you have guards at the front gate, and then maybe guards on the porch and at the front door, and maybe some guards inside the house. But then if the guards at the front gate, maybe they've been drinking too much and eating bad food, and they're sleepy and tired. And so they fall asleep at the gate. So the intruder gets through the front gate, and maybe the ones on the porch, they're kind of sleepy, and the guards get inside the door. So guards that are like in disarray, they're not alert, they allow the intruders to get into the house. So once the intruders in the house, they start making noises, and then their guards are startled, they're awakened by the noise, and then they just start shooting up everything in the house. So not only they're shooting at the intruders, but they're shooting at the people that belong in the house, and it caused everything to be in disarray. That's largely because the guards are in disarray. They're not as alert, And then when they're startled, they're over alert and et cetera. So the thing is that in that situation, the guards, which represent the immune system, is what's causing the harm as much as or more so the intruders. So if you look at the natural immune system, what happens that when you get invaded by bacteria and virus, if the immune system is robust and in shape, the virus doesn't penetrate, it doesn't get in. It recognizes the intruder and it takes care of it right away. So back to the analogy, that instead of those guards being sleepy or drunk, those guards are alert and awake. When the intruder gets to the gate, the intruder is taken care of, they're handcuffed and arrested. A photograph is taken of the intruder, passed on to the other part of the guards and say, make an identifier of this. And so this person comes again, or someone that looks like it comes again, then we can identify them more effectively. And the immune system works in a similar fashion. So when the bacteria or virus gets in it, if the innate immune system is robust, alert, then it's going to take care of it immediately, effectively, and it's going to turn itself off. But the immune system doesn't turn itself off, then you go into disarray. So then it's in disarray, that's when you see all these markers, cytokines, C-reactive protein. These are just signs of increased immune system. And oftentimes people will come to the clinic and these numbers are high, even when they don't have an acute illness, largely because the immune system is always in disarray.
Okay, thank you. So we have several questions. I'm going to keep going through. When juicing or doing smoothies, can one mix veggies with fruit?
Yes, you can. And it depends on where you are in your regimen. We've done a lot of things with the smoothie and juice. Oftentimes, when we're being more aggressive with detoxing, we'll have maybe one fruit or mostly veggies. Then sometimes, we have people, do it liberally depending on their health condition. We have not had trouble with juicing or smoothie with the vast majority of people who with diabetes. Probably because we do emphasize the greens over the fruit. But even ones that kind of do maybe multiple fruits, they tend to do pretty well. So I think that it's certainly good and it's beneficial, and you can certainly mix them. It's not a problem.
Okay, great. Kindly repeat the 3 layers of your approach of the pharmaceutical, nutraceutical, pharmaceutical approach.
Yeah. So again, the pharmaceutical should be the foundation because it's, we don't know how the body works in every intricate manner. And we don't even understand the food in every intricate manner. So when we find the food, we want to find the food in nature's close to its natural state as possible. We want to consume it as close to its natural state as possible. So that's why we come to the raw food component. But then the other aspect is that's the pharmaceutical. So then if you're putting natural food into your body, then the body knows what to do. It knows how to adjust itself and so on. But the other part of the pharmaceuticals take all the unnatural stuff out. So bring in only the natural and exclude all the unnatural. In fact, removing the unnatural is probably the first and foremost thing you have to do. And most people that I've come across are able to eat healthy food, at least some form of healthy food. But the challenge they have is the total and absolute removal of unhealthy food. Now, my definition of unhealthy food is pretty aggressive, compared to other people's definition. But be that as it may, the absolute removal of unhealthy food, especially when you're critically ill, is the first and foremost step you take. And then almost immediately after that, you're adding only the healthy stuff. So that's the foundation. That's the pharmaceutical approach. And then once you've done that, and let's say you measure levels, maybe the B12 is low, maybe the vitamin D is low, then we can target those micronutrients, target those supplements. So that's as needed. So we do the targeting of those things. So based on deficiencies, maybe magnesium is low. We have a lot of people low in magnesium here, yes. So oftentimes we're supplementing magnesium, but we also add sea vegetables as a combination. So that's the next level. And then pharmaceuticals as a last resort. And I say, and I emphasize the phrase last resort largely because, you want to make sure that you're doing everything you can to avoid pharmaceutical drugs. And then if you absolutely have to use them, then use them. And so that's the approach that we like to take.
And in that, you talked about with the nutraceuticals, actually measuring your levels to determine where there are deficiencies instead of just doing like a recommended supplement.
Yeah, by and large, yes. We tend not to recommend, say, a multivitamin, et cetera, et cetera. We typically know that a lot of people are vitamin D deficient, but we measure it anyway, so we know where they are. We measure magnesium, and magnesium is challenged because you get a magnesium and we measure blood magnesium, but we don't really routinely measure intracellular magnesium. We have a send-out lab, we can kind of get an idea of the intracellular magnesium, but magnesium is mostly an intracellular ion. And so someone can have, many people have a normal blood magnesium, but the total body magnesium or tissue level magnesium may be deficient. And so sometimes we make a clinical implication or a clinical judgment on that in addition to what we're looking on the lab. But the answer is yes, we do measure them to look at where they are, but we take that blood measurement and we put that in the context of the clinical condition. So for example, if someone has a magnesium level, maybe it's 2.0, which is normal in our milligrams per deciliter, normal in our lab. But they're having arrhythmias, they're having insomnia, their blood pressure's up. We will supplement magnesium pretty aggressively because we know that these are signs of magnesium deficiency. And even though the magnesium is so-called normal in the blood, at the tissue level is probably not normal. And so we kind of use those things in combination.
Okay. Then the next question is, how often should we detox in a year when we are apparently healthy?
That's a great question. And I like the word apparently. It varies. I would say at least once a year. I would say at least once a year. However, that put a lot of quotations by the at least. It may need to be more. It depends on the amount of pollution in your diet. So if someone is apparently healthy, and let me just kind of apply, what I think that means when I hear that. That means maybe their blood test is okay. They're not having any problems. They don't take any prescription medications, et cetera. But let's say maybe, they work long hours, or maybe their diet is not optimal. They eat some junk food here, et cetera. We really should not base our natural optimal health therapeutics based on our presence of advanced disease or lack thereof. We should really base it on what our state of health practice is. So by that, I mean the following. If you are apparently healthy, not taking prescription medications, being hospitalized under doctor's care, but maybe you're working long hours on a routine basis, or maybe your diet goes off and you eat some animal protein from time to time, or maybe something overly processed from time to time, or you go into parties and maybe have a little drink or whatever, I don't know. Then that should be your measure of what you need to do, or determining factor, I should say, of what you need to do. So for example, with that example I gave you, if you're doing those things, then you probably need to detox 3 or 4 times a year. Mm-hmm. And when you detox 3 or 4 times a year, you need to be in the mindset of removing those things that are potentially harmful. So if you're consuming I enjoy, French fries with cheese on it, once a month or whatever the case is. Well, one, by doing that, you need to detox regularly. 2, by doing that, you need to come up with a game plan of not doing that once a month. Because these bad habits are detrimental, and so it's like saying, okay, I shoot myself in the foot once a month, but I get a pedicure every other month. It's like, okay, fine, your feet are still going to look pretty mangled up. The pedicure won't reverse the gunshot wound to the feet. So again, we have to be in a mindset of, okay, I'm relatively healthy, but I don't know what that means in the absolute sense.
Okay. So we have people who are submitting via chat and Q&A. So one of the questions from the chat was, is it possible to reverse hypertension and quit medication, I think is what they meant.
Yeah, my quick answer to that is yes. It is. We've seen it in our docu-series. In fact, if you go to heartandsoulofachampion.com and you see episode 1, you'll see somebody that came in with malignant hypertension. And if you go through the docu-series, you'll see not only that we do it, but you'll see exactly how we do it. And we go through that whole process. But you know, to give a little bit more depth to the answer, you know, reversing diseases is something that the body does. And the way I like to think about it is that the body just corrects itself. It will naturally correct itself if you allow it to correct itself. So someone who has high blood pressure, they have high blood pressure because it's something they're doing to their body. And the high blood pressure is a physiological condition that is both adaptive to whatever imbalance, biochemical, physiological imbalance that's existing due to what you're doing to your body. And to some extent, it's a signal, an outward signal that, hey, something's not right. So if you had a small fire starting in your house and the smoke detector goes off and you're hearing the smoke detector, and the question is it possible to turn the smoke detector off? And the answer is yes. But you don't want to just turn the smoke detector off. You want to go in, you want to put out the fire. And so oftentimes when we treat hypertension in the pharmaceutical approach, we're just turning off the smoke detector, the alarm system, but we're not putting out the fire. The natural approach is to go and put the fire out and then let there no longer be smoke to detect, and the alarm goes off. And so that's kind of a little bit more in-depth answer. But the answer is yes, you can. We see it often. Sometimes it's more challenging than others, but by and large, it can be done.
Okay. The next question is, I appreciate the actual real world analogies too, that helps us. How often should we, no, we've already said that one. How should one eat to lower cholesterol levels and reverse hyperlipidemia?
Yeah, first and foremost, you want to remove animal protein from your diet. So that's any form of, you know, as I call it, dead animal flesh. That's chicken, fish, turkey, etc. You want to remove, of course, the animal secretions. Those are eggs and, you know, milk, etc. You want to remove processed oils. So oils that are extracted, even if they're raw or cooked. I recommend consuming the whole food. So instead of the olive oil, eat the olive. Instead of avocado oil, eat the avocado, etc. Then you want to remove processed carbohydrates. Beyond that, you know, processed sugars or the like. But once you remove all the animal protein and oils, your cholesterol will come down some, and then the processed sugars and those things that allows the cholesterol to come down more. Again, the underlying issue with elevated cholesterol has a lot to do with the metabolic derangement within the liver, and of course skeletal muscle, as much as, perhaps more so than the fat you're eating. The fat you're eating does contribute a lot of it, but those processed fats are contributing, causing a biochemical derangement, if you will. And so that's really what you want to address.
So Dr. Montgomery, this is piggybacking on what you just said, because one of the things that I find I hear a lot, and I know that we have a lot of big meat eaters probably on this conference, is number one is I don't want to give up my meat. Number two is, you know, how do I even transition? And is transitioning a good thing, or do I just go cold turkey? But I wanted to really kind of delve into that in terms of, you speak a lot about plant-based. Could you kind of talk a little bit more about that? Because I think it's one of, how do you motivate yourself, right? To go from what you're used to doing all your life, and your social life is set on that. And I think people in the United States, as well as Ghana and Kenya and some other parts of Africa, we love our meat.
No, that's fine. I tell my patient all the time, it's okay to love your meat. You can love it and keep it, just don't eat it. Loving meat and keeping meat doesn't cause the cholesterol to go up with blood pressure. When you put it in your mouth, it's a problem. So, I don't want to, break up any kind of relationship or love affairs. I just want people to, not poison themselves. So just don't eat it. That's the problem. Now, again, it may seem like I'm being, a little short, but really it's an important thing to understand, because and this gets into the psychology of all of this, and I clearly know where people are going. The reason I can say that, because I can empathize, because I've gone through this transition myself. I didn't come out of the womb eating raw vegan. I wish I had. I'm in much better shape than I am now. But long story short is that I've gone through this transition, so I get a sense for what people are going through. First and foremost, what you need to do is you need to say, look, what is important to me? Okay, because we in our lives, we have to make what I like to refer to as value proposition. Okay, you say, okay, there's a car, and that car costs so much money, and I really want that car. Or that pair of shoes costs so much money, I really want that pair of shoes. And it's going to take me, it's going to take 5 of my paychecks to get that car, and I'm going to have to, not be able to eat, or not be able to go visit my family, or whatever the case is. But if that car is that important to me, I'm going to not visit my family, I'm not do these things. I'm going to, work extra hours, not socialize with my friend, not have quality life to get that car. So that's a value proposition. Yes, this is important, so I have to trade all these things. So in life, we make value propositions. We make value propositions both consciously, and we make value propositions subconsciously. The subconscious value propositions can be the most dangerous ones, because oftentimes those things are made or influenced by addictions or unhealthy characteristics. I love my meat. I love my cheese. Well, these things are because they give you sort of a neurological high. And I've talked to people, they love their cheese or whatever so much, they're about to get an amputation, they're ready to give up their leg. And that's not a healthy value. That's not a healthy value proposition, because it's driven by a subconscious addiction to something. And so that's really at the crux of what a lot of people are dealing with. So you have to really step back and dig into that. And it's probably even more complex than what I'm mentioning here. That a lot of people have, psychological issues that's way, family issues, and maybe their mother didn't love them, or don't think their mother loved them, so they're eating food great. So that it gets really deep into this. And so if you're in a situation where I've got, I'm taking 15 medications, and I've got 5 defined health conditions, and someone tells me I just need to give up these foods to get rid of all of this pain, all of this sickness, and all of this stuff, and I'm not willing to give up my piece of chicken leg or my piece of fish, but I'm willing to deal with all of these things, then you need to step back and say there's something below the surface that's driving this, because that's not a healthy value proposition. Okay, if someone says, oh, this guy's gonna give me a brand new car, so I'm gonna give him my newborn baby for that brand new car because I love brand new cars, that's not a healthy value proposition. So we have to step back and say, okay, what are the value propositions that we're making? And so, and if I'm saying that meat is so important for me that I'm willing to, risk a stroke, I'm willing to risk being demented and not being able to advise my grandkids, I'm willing to risk an amputation and not be able to walk. I used to tell patients, what do you want? They said, well, healthy food's too expensive. I said, well, how much are your kidneys? How much are your kidneys worth? How much are your legs worth? How much is your heart worth? How much is your brain worth? So we have to back up and think of these in terms of value propositions. And we sort of look at it in that regard and say, well, wait a minute. Okay, now wait, what does this meat again? That's one. Two, the love you have for the meat, the taste in your palate, you can find new loves. It's like the woman with the boyfriend who's beating her up, but I love him. But there are other men out there. Go find somebody else who's not going to beat you, not going to be mean to you, So there are other foods that you can love, and they're as delicious or more delicious, and then they love you back. So find foods that you love and they love you back. So Mr. Meat doesn't love you, so you need to give him up.
So in the documentary that you have, the docuseries, that's on, what's the name again, Tamika?
The Heart and Soul of a Champion.com.
Yeah. So in that, I'm sure you've got people that are going through that same journey, don't you? That
Yes, ma'am.
having to give up meat. So I think that's going to be interesting to see.
Yeah, and it's not on. So, and what you have available is season 1, but we're already working on season 2, and we're already thinking about season 3. So there's going to be an ongoing process of seeing person after person, group after group, and then somebody in season 1 will show up back in season 5 and their progress. So you're going to see people's lives change before you in ways that it's not been shown, and we're working hard to really pull the curtain back and bring you into a real life approach. And you're going to see triumphs and tragedies. You're going to see, some people. So we want you to see the whole picture. So it's not like some magic show. Oh, well, just eat plant-based and everything's be great, And so you want to see, every aspect of it so you can put your arms around the concept.
Okay, great.
Great. Just a real quick question to piggyback off of the whole meat the transition.
There's always a piggyback off the meat. But
Yeah. And then I'll ask the rest of the questions. I've tried to do the transition multiple times, and I find that I've had some back and neck issues from previous car accidents and things like that. When I try to go completely off the meat, I ache in ways that it's hard. I can introduce more plants, and that's great. But then when I try to completely leave the meat, I have different body aches. Is that something where there's something specifically that I would, be missing, or is that really more like part of the whole addiction thing of, being on meat that'll go away with a detox?
Yeah, so it's a great question. And the thing is this, the aches and pains, if you've had some injuries and things like that in the past, your body will be going through cleansing. We've had aches and pains are fairly common, actually, when people go through a detox. And we had some people with some severe aches and pains. We just had them go through, just fight through it. We give you curcumin and things like that to help. But it is common, and it's really a part of the healing process as best we can understand. And what we've seen is that you get through that process, and over time that goes away.
Okay, so I just have to get to a place where I'm able to suffer through the aches and pains.
Well, you wouldn't suffer through. There are different things you can do. You can take a very high concentrated curcumin, methylsulfonomethane. These are supplements that helps with musculoskeletal issues. We're starting to use ozone therapy as an adjunct to our therapy, and that helps with reduction inflammation. Personally, I had a strained hamstring. I probably had micro tears. And I went some ozone therapy in addition to the raw detox diet, and it really helped the healing go. And one of our athletes had some knee issues, went through ozone. We had a person with sciatica who she went after about 3 treatments of high dose ozone we provided. She got much better. So there are therapies that you can utilize as an adjunct to plant-based therapy, and that's all part of the inner. And that's kind of in the second layer. You see, that's that nutraceutical as needed, and so on.
Okay, thank you.
Great question.
Okay. In lifestyle disease terms matter, is there really essential HPT?
Essential HPT?
Yeah.
You've got me on that one. I've been stumped officially.
Maybe that's hypertension, or is there?
Essential hypertension?
Mm.
Okay, essential hypertension. Okay. Yeah, HTN. Yeah. Okay. So the thing is that essential hypertension, it's a phrase we use in Western medicine when it's, you can think of it as sort of a quote unquote idiopathic cause, but really it's multifactorial. And so we have essential hypertension and secondary hypertension. Secondary hypertension if there's a identifiable cause that can be treated, then once we treat that identifiable cause, the hypertension goes away. So let's say, for instance, bilateral renal artery stenosis. So when the arteries to the kidneys are compressed on both sides, that's a cause of secondary hypertension. That if once we open up those arteries, the hypertension goes away. There's another condition, fairly rare, called pheochromocytoma. It's a tumor on the adrenal gland, cause the adrenal gland to secrete a lot of adrenaline. Remove that tumor, the hypertension goes away. We actually should have published in the case series, I'm just so busy, had a series of patients with abnormal adrenal gland function, where the adrenal glands are expressing a lot of adrenaline, and on 2 or 3 of those occasions went and removed the adrenal gland, and the blood pressure corrected itself. Now, we diagnosed that by sampling the veins, adrenal gland veins. But to make a long story short, that's secondary hypertension. Now, essential hypertension, which most people have, is due to really multiple factors. And some of the times it's the adrenal glands, sometimes they're vascular problems. But really, I see it as a metabolic problem that's causing inflammation, increased oxidative stress, and so your organs are not interacting very well. The adrenal gland is probably the feedback system is not adequate adrenal gland, and the thyroid axis could be off. The vascular structure be off. Nitric oxide production is reduced. So there's a cascade of things that are off and abnormal that's contributing to this essential hypertension. And then you may be taking some other medications to treat some other biochemical imbalance that's contributing to the hypertension. And so it becomes a big mess. And so that's why I say, okay, let's clean the slate. Nutritional detox, raw fruits and vegetables, 100%. That then starts to clean up the biochemical imbalance. And then you're able to wean certain other medication, because those medications may be causing the hypertension, contributing to hypertension, or contributing to something else, contributing to hypertension. And so you remove that, that takes out one other confusing factor. Then the blood pressure comes down, then you reduce the blood pressure medications and so on. So essential hypertension is a cascade of biological imbalances, physiological, biochemical physiological imbalances that's causing the blood pressure to be up for a number of reasons. And that's why a nutritional approach, in my opinion, is the most effective way, because you're really hitting all of those things in a uniform manner.
Thank you. So we have a question. How do you treat bedwetting in a child above 9 with nutrition?
Wow. You know, bedwetting, there's some psychosocial issue with children. And I'm not a pediatrician, but and I don't play one on TV. But to answer the question in my limited scope of things, bedwetting is an issue that deals with some psychosocial things too. Kids may be having nightmares and things. There are some nutritional things that can contribute to it. Again, I would always treat nutritional things with a healthy plant-based diet. So you want to start with that. You know, you want to make sure the kids are not consuming certain things that may be contributing to it. So when you, so let me put it this way. If there's a adverse nutritional cause to the bedwetting, you can treat it nutritionally by just removing, you know, processed foods and things from the kids' diet and adding a healthy, natural diet regimen to their diet. Dairy products may be contributing to it, et cetera. And so you definitely want to take that approach, but also want to look into other issues that may be related to bedwetting. And a lot of these are some of the psychosocial issues, but certainly a healthy plant-based diet is going to be where I would start, and then start to address those things, other things in the kid's life as well.
Okay. So the next one is how do we treat a severe acute malnutrition associated with diabetes?
Severe acute malnutrition associated with diabetes?
Mm-hmm.
Well, most diabetics are malnourished. So if you say severe acute, depends on, I'd have to give you a direct answer, I'd have to have like a clinical scenario. But to just sort of address it generically, I would start someone on a juice feast or a smoothie feast. So if they're severely malnourished, the question that rises in my mind: are they absorbing their foods well? Are they, because if they malnourished and they have diabetes, they may have other things too. So in the United States, people are malnourished not because they're not putting things in their mouth for the most part, is that they're not absorbing, well, one, what they're putting in their mouth is empty of nutrients. So that's one. And two, if there's some nutrients in it, they may not be absorbing it for different reasons. So they have an abnormal microbiome, they have inflammation of the gut, so the microvilli are destroyed, so not absorbing nutrients very well. So you want to address that. The most straightforward way is raw plant foods in a liquid state. So juice feast, and so I would treat this. That's why I treat someone if they're on life support and they have a PEG tube. I put the smoothies and juices, super greens and things in the gut directly. And so I would do that with a person who's severely malnourished with diabetes as well, because I'm likely dealing with multiple factors that's going on in that person's physiology and biochemistry, particularly at the level of the gut.
Okay, and then we're running out of time here, so we'll see how many more we can get to. I know we're gonna have to wrap up pretty soon. I think there was a question about your recommendation for treatment, I think for a liver transplants. Let me see. Yeah, liver transplant on meds. If they've had a liver transplant and they're on meds to lower their immune system.
Yeah, we've cared for a number of people with transplants, whether it's liver, kidney, or heart. Our approach is very similar. Obviously, you can't be weaned from the anti-rejection medications, but the hope is that you can get down to where you're not requiring steroids. And we try to use this as a goal for our patients. There are a number of anti-rejection medications they can use. But we use the same aggressive approach for post-transplant, post-organ transplant patients as we do for none, in which case they're on a detox to start with, and they are on a healthy plant-based diet. Oftentimes we may emphasize a high percentage of food be raw. And so, but we may do extended periods of raw foods, and it depends on where we start with them. So they're coming in, and let's say they're post-transplant, and they're very ill, because post-transplant patients, because their immune system compromised, they get infections and other things. But it's not just the compromised immune system. It's, you compromise the immune system in multiple ways. So if I'm taking anti-rejection medication that suppresses my immune system to prevent rejection, but if I'm also eating, Twinkies or whatever, I'm also compromising the immune system in another way. In fact, I may be causing immune disarray. And so you can probably, well, think of it this way. If you have a foreign organ and that's causing an immune system to be revved up, but you can suppress that, but then you're eating, say, Twinkies or chicken wings or whatever, and then that's causing immune system disarray, then that could be a problem too. And that can also, to some extent, affect your ability to keep your organ. So think of it in that regard as well. So the same approach applies in someone who's transplant.
Okay, great. Let me see. Another question is, apart from fasting, what are practical ways we can detox?
Raw fruits and vegetables only, juice feasting, and also time restricted eating. So eating between the hours of 11 and 4, 11 and 5, just eating daylight eating primarily.
Okay. And then how do you deal with leaky gut naturally?
Again, leaky gut is an inflammatory process. And so that's going to be a natural plant-based diet. We oftentimes will put patients on a juice feast or a smoothie feast because if they have a leaky gut, they may have like irritable bowel syndrome or inflammatory bowel disease. And so they may not tolerate solid raw foods or even solid cooked foods very well, but cooked foods may worsen inflammation. So we may put them on a smoothie feast or juice feast, at least for, say, 10 days, maybe longer, to kind of let the inflammation of the leaky gut calm down.
Okay. The next question is, hold on. I'm going to put the website information in there so that someone asked for that. Could you elaborate more on the toxins examples that are found in the body, which come out as the patient gets detoxified? And what's your comment on some of the practices of detoxification where patients step their feet in some liquid, very common with Chinese practices?
Maybe very snappy answer to that question, Dr. Montgomery.
Yeah, so the quick answer to that is simply toxins exist in many different forms, and it's very difficult for me to really elaborate, largely because a toxin could be just the malformation of a molecule that's supposed to be there. And so I tend to refer to them as free radicals as one example. And these free radicals are molecules that, say, missing an electron or something like that. And so, antioxidants will donate an electron to a free radical. So that's an example of a toxin, but there's a complex issue that we deal with in terms of toxins and the like.
Okay, and then what is the base for smoothies? Currently, I use keto yogurt.
I wouldn't use a keto yogurt. Oftentimes it's an animal-based yogurt. I would use like a fresh coconut water could be one base, good alkaline water. I like coconut water as a base. If you don't like coconut water, then water, and then you can add things like a raw tahini or avocado or something along those lines to kind of give it some thickening.
All right. Well, we
I
had
want to take a minute to say hello to my friend Kim Williams. I see he's in the studio. Hello, Kim. I hope things are not too cold in Chicago these days.
Hey, Baxter, how are you?
Fine, thanks.
Yeah, no, that's Chicago is long ago. So that was like 7 cities ago.
Oh my goodness, I'm sorry. I keep forgetting. You just
not just chair of medicine at Louisville. That's one thing.
Right.
But the Santa Barbara course, I taught him that. I'm here at CRT, so it's in Washington D.C. So
oh my goodness,
on my way to San Diego to get to New Orleans. So hopefully I'll see you there at the American College of Cardiology meeting.
I was planning to go to Heart and Rhythm in New Orleans. So ACC is in New Orleans too?
Yep, it sure is. Yep.
That's next month.
It is. Yeah.
Is it too late to register? Maybe, I know important people like you, maybe you can get it out.
Yeah, no, it's it's a big deal for me this time. They haven't had me on one of those late breakers since I was ACC president, because I don't know what you have to do to be on one of them, but they're going to be they wanted someone to talk about nutrition and inflammation, because Paul Ritker is going to unembargo his study on inflammation and how to get rid of it. And we know the best way to get rid of it, because you're doing it every day.
Wow. Well,
your farm and your restaurant and your center.
I'm going to have to check my scheduling. I have to get out there. I didn't realize ACC. I mean, I'm so busy in my cave working. I need to stick my head every now and then and see what's happening in the real world. But I'm going to have to get out there.
All right. Well, text me if you get there.
Wonderful.
I want everybody to know that these are two of the leaders, the premier leaders in the field of health as it relates to nutrition and chronic diseases. So you all are awesome. And it's really nice to see you together.
Right. Well, I think we complement each other. I'm very strategic. He's tactical. I got all this academic stuff. Just wait till you see these slides, all these studies. He's putting it to work in the ground, and ever since I was at your place and you're talking about doing the farm, it hit me, if people aren't eating out of the ground, then they end up in it.
Wow.
Okay. Now, look, Dr. Montgomery, we so much appreciate your time and your great presentation. I believe the audience are very, very happy And the audience, can we show our appreciation by a thumb up, if you could? Thumb up, in electronic thumb up, to show our appreciation for Dr. Montgomery. Thank you. Look at the thumbs flying
All right.
all over. Thank you
And-
so much. You know what I like about your presentation, Dr. Montgomery? Your real life illustrations. Those are wonderful, you know, and you can really hit the nail on the head by, you know, trying to illustrate those real life, you know, using real life time illustration on how we can choose the right health practice, right value proposition. I like that. We thank you so much.